as you said, my name is Dimitrios Pousios. I'm a consultant heart surgeon in Southampton, Wessex Tendineae. And I've been working in Liverpool up until September last year when I joined Southampton. So therefore, I kept still my honorary senior clinical lecturer post at University of Liverpool Medical School. My subspecialty interest is clearly mitral valve. To give you an idea a bit of my background in terms of how many cases I've done, I've operated around 400 mitral valves in my career, which is a reasonably nice number. To give you an idea, the probably maximum number that the UK surgeons performing in the end of the career reaches around 1,200, 1,300. So without further ado, I'm just going to start a little bit with the history of why the mitral valve is called mitral. I'm sure that people may have heard that it has to do with the bishop's mitre from, I think it's probably Catholic or High Church. And it's quite difficult sometimes to imagine it, but indeed it is like an inverted picture of the mitral valve with the seat for the head, if you can imagine, that's the annular plane, and the two leaflets with the attachment of the chordae to the papillary muscles are the two spikes of the mitre. And when we look at the mitral valve to find out the specific anatomical components and a description that's appropriate for the valve, this is the picture that you see when you watch the valve from the surgeon's view on either stenotomy or a minimally invasive approach. This is the picture that you see here on the photo. Just to give you an orientation, the head of the patient lies here, the legs lie on the right of the screen. Everything that you see written as A is the anterior leaflet. Anything that you see numbered with and also with a P is a posterior leaflet. And we have two other things that are called the anterior commissure, the slide here, and the posterior commissure here. The LFT and the RFT are anatomical structures that have to do with the fibroskeleton of the heart. This is the left fibrous trigon and the right fibrous trigon. You'll see a little bit more about it. So what is interesting about the anatomy of the mitral valve is that it has relation with many other things. It's quite perhaps one of the very unique parts of the heart which has a relation to a lot of things. So it has a relation to the AV node, the circumflex artery, to the coronary sinus, and also the annulus of the mitral valve is not just a given rigid thing. It moves, it changes. It changes in diameter during each systole of the heart with at least 20% change of the dimensions. It changes shape from elliptical, as you can see here, it goes to circular. And also, as we said, anteriorly it's attached to the fibroskeleton of the heart, which is somewhere there. And that limits the flexibility of the anterior part of the annulus, while the posterior part of the annulus, that semilunar structure, is much more flexible and it's opening and dilating when the heart is beating. We also have to do with the aortomitral continuity, and there you can see much better. This is a picture of joint, the aortic root, and the mitral valve. With L is the left coronary sinus, and that's the left main coronary artery going to the circumflex artery into the LAD. That's a little bit of a remnant of the LAD, and that's the non-coronary sinus. And you can see this part here, that little edge is effectively part of the fibroskeleton of the heart. This is the anterior mitral valve leaflet. This is the fibrous trigon on the left. This is the fibrous trigon on the right, and the posterior leaflet. You can see how close the mitral valve lies to the aortic root and the aortic annulus effectively. If we see it here, it's even better. And you can see the difference that the dominance of the circulation of the coronary arteries makes to the relationship of the mitral valve. On here, we have a right dominant system, and here we have a left dominant system. Just to remind people, when we say dominance in coronary arteries, we refer to which vessel, the right or the circumflex artery, is giving the interventricular artery. And you can see here, this is the dominant left coronary artery system, the left main stem. LAD is going somewhere on the back, we cannot see it. In here, you can see the circumflex artery that goes into the atrioventricular groove, and you can see how closely it snags the posterior annulus of the mitral valve and then goes even more distal and becomes the interventricular artery. In contrast, on the right dominant circulation, you can see the dominant right coronary artery, and here on the posterior annulus of the mitral valve, pretty much nothing's there. The circumflex artery is this one, reaches somewhere at that point. It still has some relation, and it's something we look on when we operate, especially on this corner, but certainly it's not as close to the annulus of the mitral valve as before. A little bit more, we said about the chordae. The chords, the chordae tendineae, they are connecting the leaflet edges with the papillary muscles. And it's much more obvious here. Here we have a sliced heart. Effectively, the posterior leaflet is sliced in half. You have an intact, stretched anterior leaflet and two parts of the posterior leaflet here and here. Again, this is the anterior commissure, the posterior commissure, left and right fibrous trigon. This is the A1 scallop, and these are the little parts that you can put some imagination on to think of the anterior leaflet. A2 is the big main part of the anterior leaflet. A3 is the smaller posterior part of the anterior leaflet. P1 and half of P2 of the posterior leaflet is here. The other half of the P2, you can imagine it when it comes around into the back to become one, and P3 is over here with the two commissures at these points. And you can see the cords connected with the posterior papillary muscle and the anterior papillary muscle. That's not always the case. You have, most of the time, my experience, you have more than the two papillary muscles. And occasionally, very rarely, of course, but it has happened to me, I've seen it, there was no papillary muscle, the cord were coming just directly from the main, let's say, wall of the left ventricle, but they were still connected. It's quite important when you repair, and depending on the technique you follow, that you know exactly where the cords are coming on which papillary muscle and where you're doing. If I go a little bit more and I show you a little bit the function of the valve, again, as a schematic, just to put it on a bit of silence, you can see it. It separates the left atrium, the left ventricle, blood's coming down, as we all know, goes into the aorta with every diastole and systole moving. And you can see here the pathophysiology of when we have, for instance, a ruptured chordae, how the valve is just departed from the annular plane and prolapses into the left atrium. How do we assess the mitral valve disease? Mainly with the stethoscope, to start with. And I'm saying that, and I'll explain from an anecdote of one of my recent experiences, how important it is, especially or even more when you're a young doctor, to keep an eye on the stethoscope, still use it, still trust it for diagnosis. Obviously, we have echocardiography, which is the gold standard, with a transthoracic echocardiogram, which is the usual modality. But ideally, for mitral valve and mitral valve surgery, especially, we need to have a transesophageal echocardiogram. Also, MRI is important. It quantifies sometimes better the regurgitant volumes on a leaking valve. Mainly, you want it as a good assessment of the heart function, but still, my planning on operating or assessing somebody for an operation on mitral valve surgery, it would be based on the echocardiogram. In an ideal world, the transesophageal echocardiogram. Just to give you an idea how the assessment of the echocardiographic pictures of the mitral valve is taking place, these are three different orientations of the mitral valve. This is the normal view, anatomically. Again, head of the patient is on the left side of the screen, legs on the right side of the screen. This is an inverse picture, which is effectively what you see on TOE. And why you see that? Because the TOE probe, the esophageal probe, is in the esophagus, which lies on this part quite deeply, of course, but sees the valve upside down in a way. And this is the actual surgeon's view, because we are moving the patient and we are setting up the valve so it faces us in that configuration. In real life, though, this is the proper lying of the valve. And again, this is a different view. It's called mid-esophageal four-chamber view, where the probe of the TOE machine is somewhere in the middle esophagus and at 0 degrees. And therefore, the plane of the view cuts this plane here. This is the tricuspid valve. This is the aortic valve. This is the pulmonary valve, and this is the mitral valve. And you can see here the fibrous trigon of the heart. The fibroskeleton is this one here. So in reality, you can see how close the valves. In real life, they're actually even more closer to each other. And since we are talking about that, that's a picture of a mid-esophageal, quite zoomed, obviously, on the mitral valve view at 0 degrees with a esophageal echo scan. I know it's a transesophageal echo because it has the degrees of the probe here. So what you can see here is this is the left atrium on the top of the screen. the left ventricle, you can see a little bit the aortic valve over there. And this is the anterior leaflet of the mitral valve, and this is the posterior leaflet of the mitral valve. Clearly, in this case, there is a posterior leaflet prolapse with some ruptured chordae, and you can see the posterior leaflet jumping inside the atrium instead of staying in the plane and in contact with the anterior leaflet. This is what we call, that's a view at 60 degrees, with again with the transesophageal. Here we see the valve moving. You can see now that the valve is not as thin as in the previous one. That's probably has some element of rheumatic disease. It's a bit more thickened or myxomatous degeneration disease anyway, but that's another view of the valve. And again, now we're moving to 90 degrees. So the probe is turning around and slowly takes different parts of the valve. And we see now again, a prolapse of the posterior leaflet while the anterior leaflet remains on the plane of the annulus. And what happens when we put color flow Doppler? We can see the eccentric regurgitant jet. So you can see here, there shouldn't have been any color at all inside the left atrium, left ventricle, left atrium. Nothing should have been there, but clearly through that prolapsing posterior leaflet, you can see a jet going in. And by the size of the jet, I can tell you already, this is a severe leakage of the mitral valve. And again, this is what we call mid-esophageal long axis view of the aortic valve. It's a view that we use to see the aortic valve quite nicely. Just to familiarize everyone, I'm just going to pause it for a second. This is the left atrium, left ventricle, aorta, aortic valve, mitral valve. This, by definition, this leaflet here, by definition, is the right coronary cusp of the aortic valve. This leaflet could be either the non-coronary cusp or the left coronary cusp, depending on which angle we are taking. Anterior mitral valve leaflet, posterior mitral valve leaflet. And you can see clearly that there is a prolapse of the posterior mitral valve leaflet, and we'll talk a little bit about this pathology. Virtually 80% of all the referrals we get or the disease that we get with a mitral valve regurgitation have a similar picture like this one. On the other hand, if we have a narrowing of the mitral valve, we assess it usually by pressure half time and mitral valve area. Pressure half time, as we know, is the time that it takes for the pressure to go to equalize at the half point. And through that, with this formula, you can calculate the mitral valve area, in which case here we have 1.17 square centimeters. That's quite narrow valve. And that assesses the degree of the mitral stenosis. Again, there are some limitations if you have aortic valve regurgitation, which impairs the valve opening of the anterior mitral valve leaflet. But for main reasons of understanding mitral valve stenosis, we're looking at pressure half time and mitral valve area. I mentioned already that we have three effectively types of disease in the mitral valve. We have regurgitation, we have stenosis, and we have mixed disease. The vast majority is regurgitation of the mitral valve. It has different etiologies. It can be degenerative due to cellular matrix changes, which varies from the initial stage of them, let's say, fibroelastic deficiency, where tissues are becoming thin and then eventually they snap, elongated snap. We have myxomatous disease, what is called Barlow's valve type, and I'll show you some pictures of that, it's quite impressive. And obviously we have the known elastic syndromes, if I can call them like that, Marfan, Ehlers-Danlos, and so forth. We have also calcification that can cause mitral regurgitation by not allowing the leaflets to move as flexibly as it should have been. And therefore, from there on, we have inflammatory processes. And for acute regurgitation, we have infectious reasons, infective endocarditis, for instance, or ischemic mitral valve, where the valve itself hasn't got a problem. The problem belongs to the heart. The heart is not moving, the lateral wall is not moving. Therefore, a part of the valve, and that's usually the posterior leaflet, is not moving equally and doesn't coapt. Therefore, we have leakage. Also, I would add that there is a quite strong element of functional regurgitation that has to do with annular dilatation, either because of AF, which makes the chambers, the atrial chambers big, therefore the annulus big, and also poor heart function where the valve just doesn't coapt. These are more diseases of the atrium and the ventricle respectively, but they do affect and cause problems with the valve. They are not disease of the valve. Symptoms-wise, personally, when I see patients in the clinic, I call that disease to let them understand better the iceberg disease. It lies under the surface, it damages the heart under the surface, but doesn't cause a lot of symptoms. Fatigue and weakness, sleepiness. Quite a lot of patients tell us when they come to the clinic, you know what, I'm 60, I think I'm getting older, or I'm going for a walk and then I come back and I just fall on the sofa, half asleep, and I don't have any energy. These are very vague symptoms. You could argue I have them after 3 days of being on call, but they have to be assessed with other things as well. But you have to have a degree of suspicion for mitral valve disease when you hear somebody saying that they are going into that direction. Clearly, if the situation is worse or already prolonged, you have dyspnea or orthopnea or paroxysmal nocturnal dyspnea, PND. My experience, very, very few people present with PND. Usually by the stage you have dyspnea or orthopnea, you will be picked up and directed for treatment. Eventually, if the situation stays for a long time, you start developing pulmonary hypertension and you have symptoms of right heart failure with peripheral edemas and so forth. If you examine foreign mitral regurgitation, the signs you have is a displayed apex beat. And that's because the ventricle becomes bigger. The more the valve starts to leak, the more the ventricle has to distend to fill to counteract for the loss part of the stroke volume that goes the wrong way. Therefore, you have hearts that normally, when you open the chest on sternotomy, you see pretty much all the heart in front of you. In mitral valve disease, most of the time, the heart is lying on the left side more and more. And the more prolonged the presentation, or delayed the presentation, the more the heart goes to the left. You have apical thrill, you have third heart sound, but quite importantly, you have an apical pansystolic murmur with radiation to the axilla. And eventually, if you have pulmonary arterial hypertension and signs of right heart dysfunction, you have right ventricular heat. Before I go to show you some pictures of what the degenerative disease is, I promised that I would say the importance of stethoscope, and I would just say an anecdote story of during the pandemic, we had a referral in Liverpool of somebody from a peripheral hospital, which was a 59-year-old patient on the ventilator, not being able to be disconnected, probably COVID. Negative samples again and again and again, negative PCRs, negative LFTs, it must be COVID. They were about to start discussing about withdrawal. And then in actual fact, the FY that was attached to the intensive care on that particular hospital put a stethoscope on the left side of the patient and heard a murmur. You can imagine the speed of the call to our hospital for referring the patient who got transferred and had an operation for an acute papillary rupture, papillary muscle rupture and acute MR, which was effective because pulmonary edema. Having said that, there was no COVID really from that point. So it's quite important that, yes, we don't do it, and I can declare guilty on that. It's easy to see the echoes, but please use the stethoscope. It's quite a useful tool sometimes. When I was describing about the degenerative degrees of the degrees of degenerative disease, we talked about the fibroelastic deficiency. That's the first stage, or the relatively older people's disease of connective tissue. You can see it's more about people above 60 years of age. Again, we have seen it on younger one, but it's more often happening on older people. It has a short duration of disease. There's no family history usually. Again, you have the pansystolic murmur. And when you see the echo scan, most of the leaflets are actually thin. If you remember the first picture I showed on the echocardiogram, and usually we have some ruptured chordaes and a single segment prolapses. On this, for instance, picture, you can see this is the mitral valve, and again, anterior leaflet, posterior leaflet. This is the P2 scallop, and you can see the P2 scallop looks thicker compared to the rest of the valve, which is pretty much normal, slim, normal, and almost transparent, as you can see. But there are 1, 2, 3, 4 cords snapped. So this is clearly an example of fed disease. Here is the same valve, but without the water. And you can see on the assessment with the nerve hook, we can see the snapped chordae and the parts of the valve that are prolapsing. Mitral valve repair on those are less complex. I agree and disagree. In my opinion, my experience, the more tissue you have, the better it is. You have something to come across the other side and coapt. Especially with a very thin, the rest of the valve being very thin, and you have one point only, you have to make the repair very good. But it has a long, good-term result. When we go to the other side of the spectrum, you have Barlow's valve. It's a myxoid infiltration. Usually it's for young people, less than 60 years of age. They know about that because they know somebody picked them up with a murmur or a prolapse years ago. There is some degree of family history and occurrence on those. They present on auscultation with the mid-systolic click and late systolic murmur. And why late? Because the valve, when it coapts, it does that. Comes into the level of the annulus and then goes upwards. So at the very, very end of the systole is where you have the leakage. On the echo, as I showed you the second picture where the valve was a bit more thickened, you can see bulky billowing leaflets. Lots of things, lots of segments, lots of scallops are prolapsing. It's not the picture we saw before with only one part prolapsing. This is pretty much the whole valve out of the annulus and onto the atrium. There is excess tissue, and the repair is theoretically more complex. Again, there are variable degrees of severity of this disease, but certainly there is a lot more tissue. As somebody has described it, it's a bunch of hemorrhoids. So there are ways that you can repair that, and I'll go a little bit on when I talk a little bit about the surgical repair, but for that matter, this is a Barlow valve. When we classify the pathology or the mechanisms, we use Carpentier's classification, and I'll show you a little bit later who's this guy. He was a French guy, Alain Carpentier. He was the pioneer of mitral valve repair surgery. So he had said that there are three types of mechanism where the valve is leaking. Or type 1 is where we have normal leaflet motion, but there is no opposition between the two leaflets. Either anterior or posterior, it doesn't matter which one of those, but you have a distance. Type 1 is by usual definition, it's either due to AF or functional regurgitation from a dilated poor ventricle that the annulus is just coming apart. The valve itself is pretty much normal, but there is really a gap between the two parts of the leaflets. Type 2, we have a prolapsing leaflet motion that usually refers to the fibroelastic deficiency or possibly to a Barlow valve, you could call it, where you can see one leaflet. Let's suppose that this is the posterior leaflet, has already elongation of the cord, is already prolapsing. When it starts prolapsing, the tension and the forces that are applied by the ventricle on its systole are starting to become different. And the same way that you have a tarp in your garden or a gazebo, and one part of that goes away and there is wind, it will just tear the whole thing apart, and then that's eventually when you get the cord to rupture. Type 3 is when you have restricted leaflet motion. You can see here the cords are not as long as they should have been. They're more thick and they are more tense and shorter. But usually either because of they have a problem themselves or because the heart itself doesn't allow them to move in a longer axis movement. And lo and behold, when I was saying about the type 1 mitral insufficiency, we have the annular dilatation. You can see here the annulus is quite big and there is nothing, there's no coaptation, and you can see this really, really big jet going to the left atrium. This is left atrium, left ventricle, aorta, going back and actually directed a little bit towards the posterior side of the left atrium. Again, when we have it, as mentioned before, atrial fibrillation, degenerative disease, ischemic dilatation of the annulus, or cardiomyopathy, poor heart. You could also have it when you have leaflet perforation from endocarditis or from trauma, quite more rare. The type 2, in this picture here, you have a Barlow valve, but that applies also to the simple fibroelastic deficiency. You have ruptured and elongated cords, usually degenerative, very rarely trauma or endocarditis, much rarer, or papillary muscle elongation and rupture. But the main thing that you have a type 2 mitral valve regurgitation is degenerative disease. Again, lots of mitral tissue in the leaflets, but one is lying on top of the other. Therefore, blood is going to escape. And therefore, usually you have an anterior directed jet that makes a circle around the atrium. Type 3A is restricted leaflet motion because of problems with the cords or the papillary muscles. Usually rheumatic, the vast majority, sometimes other diseases like lupus or sometimes pharmaceutical. I have to say I haven't seen none of those ever. You can see here the leaflet are not looking normal. They're more yellow, they're more thick, they look more ugly, more wrinkled, almost like they have had some kind of scar post-birth. And the valve itself is quite smaller, and there is a degree of narrowing as well. You can see here the commissures are almost joined here. Type 3B is when you have restriction of the valve movement. So the valve is all right, the cords are okay. However, the ventricle is not moving, and not moving here is just to show you again, left atrium, left ventricle. This is the septum. This is the posterior lateral wall. So let's suppose that this person had a circumflex artery occlusion and an MI that took with it left the lateral side of the heart. This part of the muscle is not going to move. So you're going to have a move of the anterior leaflet, but you can see the posterior leaflet doesn't almost exist. That's a more usual acute situation. So when are we supposed to see these patients? When are the cardiologists supposed to send to us? And when do we offer surgery? For regurgitation mainly, we have class 1 symptoms, and I just remind everyone in case you don't remember it. Class 1 is where a treatment is definitely indicated. Class 2A is probably indicated. Class 2B possibly and likely indicated. Class 3 not indicated and actually contraindicated. So class 1 means definitely indicated to take somebody for consideration for surgery when they are symptomatic with severe mitral valve regurgitation, or when they have asymptomatic mitral valve regurgitation, but still severe, and the LV function is dropping, so they don't have the usual 60-65% ejection fraction, or the end systolic diameter, that's the ASDD, so of the ventricle is more than 40 millimeters. We don't count the diastolic diameter. It can increase in size, but at the end of the systole, it doesn't have to be, it should not be distended. Class 2A, very probably the indication for surgery, is when you have an asymptomatic severe mitral valve regurgitation with preserved left ventricular function, but there is new onset atrial fibrillation, you have high pulmonary pressure at rest, or more than 60% with exercise, and also people that we have a significant chance of repairing in an experienced center with a high volume. Where we shouldn't intervene is when we have asymptomatic severe mitral regurgitation, good left ventricular function, no pulmonary hypertension, no dilatation of ventricle, and we are not really sure that we can succeed with a repair. And definitely when you don't have severe mitral regurgitation. The evolution of surgical management, there are not really a lot of randomized trials, and most of the management has been from large cohort observation studies. This is the chapter that I was telling, Alain Carpentier, and this was the seminal paper, the cardiac valve surgery, the French correction, as he called it, where with his techniques, we managed to repair more than 95% of degenerative valves. They do have a risk of failure, and as you can see on posterior leaflet prolapse, there is a risk of failure of 0.5 per patient per year, much worse for anterior leaflet prolapse, and not so good as well for bileaflet prolapse. You may not sound a lot, but if you think about you operate on somebody that's 50 years of age with degenerative valve and has a posterior leaflet, straightforward repair, they live to 80, that's effectively a 20% chance of failure. So it's not, one and done. There is future, unfortunately, on these patients. But this guy helped us understanding the natural history of the valve when it's leaking. As I mentioned, the myxomatous valve, you get a high percentage of repair. But more importantly, you can see what happens if you don't do anything to these patients. So there is quite a nice paper in '96 in the New England Journal of Medicine, which took 230 patients with severe mitral valve regurgitation, but without any treatment, surgical treatment, only optimum medical treatment. In any case, the optimum medical treatment of the time. They followed them for 10 years, and you can see that the mortality was more than 33% from cardiac causes at 10 years. And at 10 years, they had a 90% rate of surgery or death. So therefore, they either had died or had been operated. And surgery associated with a reduced mortality rate. When you break them down to people that are symptomatic with class 3 or 4 New York Heart Association, and compared to class 1 or 2, you see the difference in mortality. Annual mortality of 4% for people that are not symptomatic. When you have symptoms, you just go down. When you have drop of the heart function, similar difference, statistically significant. And the same applies when you have repair. So for instance, this is the survival even when you have a repair of the valve, which is quite depending on how the heart function was beforehand. And you can see here the expected survival after repair on someone that had retained heart function is good. It's almost like normal. Conclusion, surgery before the ejection fraction falls, and equally if there are minimal symptoms. And again, the same difference in survival post-repair of the degenerative disease if you have already developed atrial fibrillation. Again, conclusion is operate before AF if possible. And why do we think that it's quite improved with repair? Because it has lower operative mortality. It's an easier operation. You do less things to the heart, if you know what you're doing, of course. You preserve the geometry and the function of the heart. You have fewer late complications due to structural valve deterioration. Therefore, you don't have to choose if you put a mechanical valve that you will have warfarin and all the effects of high warfarin dose. And equally, you don't have to re-intervene in a biological valve that has gone in degenerative itself. And also the chances of endocarditis are considerably less with a repair. And again, you see here the difference between repair and replacement. And that's why we prefer to repair people on posterior leaflet prolapse. The more you go to the right, the more you go to anterior leaflet prolapse. Difference between repair and replace is not particularly significant. A little bit about what we choose if we have to replace a valve in the mitral position, and that applies either regurgitation that we couldn't repair or we failed, or stenosis, mechanical versus biological. The main thing is we offer mechanical valves on people less than 60 years of age at the aortic, but more importantly, 65 years on the mitral position, or if they're warfarin already for a mechanical aortic valve, or they have to be on anticoagulation for other comorbidities that require, they have a high risk of thromboembolism. Biological prosthesis, again, if the patient wants it, when there is no, where we cannot achieve anticoagulation or we should not have anticoagulation. And again, bioprosthesis should be considered in young women contemplating pregnancy. I would try to repair if that's the case in a young woman at pregnancy age. On the other hand, we have the mitral valve stenosis, mainly one etiology, rheumatic fever. Very rarely you have congenital reasons, fibroelastosis, carcinoid, which is usually on the right side valves, and quite exotic situations. Left atrial myxoma, it causes stenosis by being there, not affecting the valve. So when you take the myxoma out, the valve should be all right. Symptoms, exactly the same. Much longer the latent period in mitral valve stenosis. The same triplet of fatigue, weakness, dyspnea, and so forth. But also because the disease on the mitral valve when it's stenotic distends the atrium more than the ventricle, you can have huge atria, you can have mega atrium. The bigger one I have seen, biggest one I've seen is more than 13, 14 centimeters across. So it can cause distension to adjacent structures. You can have hoarseness, you can have dysphagia, you can have wheezing and breathlessness by pressing of the bronchus. Signs, again, non-displayed X-fix beat, opening snap, because you have now a much more harder and snappier valve. And again, you have a mid-diastolic rambler murmur at the apex when the heart is filling. When do we operate on mitral valve stenosis with rheumatic people? Don't forget, on those people, there is a place for balloon valvuloplasty. It has very good results done by the intervention cardiologist with long-term results in quite a lot of situations. But a class 1 indication for us is when you have moderate or severe mitral stenosis with symptoms, where we cannot have any more balloon. And when that's usually when you have regurgitation. When it's already leaking, the cardiologists are very, very unhappy to proceed because they can cause much more leaking of the valve. The heart can tolerate stenosis. It cannot tolerate regurgitation. It should probably be considered when you have stenosis with pulmonary hypertension or symptoms which are less, but again, not suitable for valvuloplasty. And it could be considered if you have recurrent embolic events, if you believe that they are connected with moderate and severe mitral valve stenosis. It's quite timely that recently there is a paper that has been announced in the European Society of Cardiology meeting just a couple of days ago that they found that warfarin still has to be given to the people with rheumatic heart disease compared to NOAC because the results are much better for warfarin. Quite interesting and timely. A little bit about endocarditis. It's quite an unusual thing to have, but we see it not too infrequently in heart surgery. Usually you have it when you have abnormal valves or prosthetic material. Microbiology of it, as in all endocarditis, 85% you have a culture, staph and strep, the usual bugs, or occasionally you have negative culture endocarditis with Haychek group, fungal endocarditis, and other exotic diseases. Most of the time, though, this is where you're lying. We're using the Duke's criteria. You need two major criteria: blood culture positive, or evidence of endocardial involvement with echocardiography, or new regurgitation in a valve that was previously okay. You need two major criteria, or one major and three minor, minor being predisposing circumstances, fever, vascular phenomena, immunologic phenomena, or microbiologic evidence. When we operate on mitral valve, or for that matter, any kind of left side valve, aortic or mitral, when you have heart failure, when you cannot control the infection with antibiotics, the patient remains septic, and to avoid embolism, when you have a much big vegetation, either more than 15 millimeters, or you have vegetations, but also with other confounding factors. A little bit about the technique. I know it's not perhaps in the scope of your level, but just to show what we do, this is the original technique that Carpentier showed. You have a prolapsing P3 on this one. Again, anterior leaflet, P1, P2, P3, the scallops of the posterior leaflet. What they were doing they were excising it, and then they were stitching it shorter. They were tightening it. Again, all the three methods that you see here, they are all accompanied by annuloplasty with a prosthetic ring to make the annulus more rigid and avoid further deterioration or relapse in the future. This is a much bigger valve. That's a Ballo type valve with a very, very big P2 scallop. In that case, they did a quadracular resection and they approximated the other two parts. And this opening here is called sliding annuloplasty to make more flexible and be able to bring it together. And you end up with that, plus the ring at the end. More modern method developed over the last 15 to 20 years, more in conjunction with minimally invasive surgery, is where we are using artificial cord. So in this occasion, we wouldn't take this scallop off. We would just attach neocords made out of Gore-Tex to the papillary muscle and to the edge of the prolapsing part and just prick it out. And again, an annuloplasty ring on the bottom. Again, that depends on the philosophy of the surgeon, the training, you have to know all of these methods. I would probably prefer to do that. Retain and what we call respect the valve rather than resect the valve and use Chordae. This is a little bailout, which is called Alfieri. So it's an edge-to-edge repair with a stitch. So effectively, you can see the valve, the anterior leaflet, the posterior leaflet. You tie the middle of the valve together, and then you end up with two different valves. If you think about it, one is in the anterior side, one on the posterior side. It's called the bailout technique, although it has been used, and I'm one of the people that like it to use it on certain occasions, especially on bileaflet or anterior leaflet prolapse, because it's quite foolproof. If you tie those two parts together, there's no chance that they will prolapse in the future. And obviously, we have the artificial valve. I just use the biological valve here, and I'll show you some videos a little bit to see how it works. So the approaches what we have, the sternotomy approach. So if I take you to a point just to see a little bit here. I'll try to explain as much as I can. So in this side here, they have already placed, they're trying to replace the valve through a sternotomy. These are pipes that connect the SVC and the IVC to the machine, and the aortic pipe somewhere there. Head of the patient on the left, legs on the right always. This is the left atrium opened, and this is the mitral annulus. They have resected the valve, and you can see all the sutures that are implanted around the annulus and connected to the valve. At the moment, they're connecting them. In actual fact, that's a ring. I apologize. It's trying to repair the valve here. And you end up with what we call parachuting the prosthesis. You're tying the sutures down to the ring. The little black part is basically a plastic holder because you don't want to over-restrict it. The ring is flexible. And then once you tie all those, you remove the plastic holder. And you end up with a valve in place with a ring around it. How do you test that this is working? Quite crudely, with water. So you infuse water and you just test the valve. That is not leaking water. One of the modern approaches is minimally invasive surgery. As you can see here, this is an approach. Again, the head of the patient is here. This is the abdomen, this is the chest. This is the main working port. They have used a soft tissue retractor, but also a sternal retractor. So you operate on the mitral valve of that. This is a camera that you can see, and you get access to the patient circulation through a groin incision. You see through this little view, and you can see the aorta. They're trying to clamp the aorta and proceed. I'm just going to process a bit. So pretty much what we saw before, only this time, this is the mitral valve, again, posterior leaflet here, anterior leaflet here. This is the left atrial opening. So they are implanting loops. You can see the loops. And if you remember the technique that I mentioned that is used mostly in minimally invasive surgery, they connect these loops to another string, and that string is connected to the valve. So you tie the valve, the new cords, you put the ring exactly as you do in an open stenotomy. And from there on, the operation is pretty much the same inside. Even more exotic, robotic surgery, where you can see the surgeon basically operating far away from the table. The robot arms are doing the job. But if you saw already, there was a gentleman next to that, which is the assistant. In actual fact, the assistant does more things in the operation rather than the surgeon, because all the instrument sutures are passed by him. And you can see the robot here. Few words about the minimally invasive mitral interventions without going on cardiopulmonary bypass. This is pretty much what people call mitral clip, but in reality, mitral clip is just a commercial name. It's edge-to-edge repair, transcatheter edge-to-edge repair. And you can see how it works. It's done by the cardiologist mostly. So they catheterize the patient. You can see the arms of this little device is trying to grab the two parts of the mitral valve. As you can see here, it doesn't succeed. So you can see the regurgitant volume, the blood going to the left atrium, left ventricle, aorta as before. And as you can see here, it managed to grasp both of them. And this picture here is pretty much the picture of the Alfieri edge-to-edge repair that I described. You end up with this clip in place and holding the valve in place. The transcatheter mitral valve implantation technique is not yet as developed as the TAVI, as the aortic valve that you hear everywhere. It's something that's still not in a full-blown use. It requires a lot of calcium in the valve for the valve to be deployed, and that's usually not the case. But this is the way it's applied. It's a replacement, effectively, of the valve, keeping your own valve and putting this valve in place. Unfortunately, it has very, very limited indications for that. But this is how it works. You can see the new valve in place and the leaflet with the cords of the native valve just all over outside the previous valve. So just to conclude, mitral valve disease and surgery is challenging. It's nice. It's the closest in heart surgery that I could say resembles cosmetic plastic surgery. You have to make it look nice and work nice. Unfortunately, the patients are usually sicker and the hearts are already more tired. I wish that they will all come at the first stage, but most of the time they come when they have developed pulmonary hypertension or heart function that's dropping or AF. One wise anesthetist had told me once when I started, Dimitrios, mitral valve surgery is actually awfully simple, but occasionally can be simply awful. And unfortunately, in cardiac surgery, you know, as my favorite comedian, Rodney Dangerfield said, if it goes well, I'll be in the hospital for a week. If things don't go right, I'll be out in an hour and a half or two. Probably more than that when you're running on ECMO. Thanks very, very much for your attention at the time, especially when it's Monday and bank holiday Monday weekend.